presenting to us her talk titled Race and Attitudes Towards Treatment Seeking. She is a first year in the clinical psychology program working with Dr. Jennifer Chavez in the Food and Personality Studies lab. And she said she's still figuring out her research interests, but she's generally interested in mood, race, and treatment. And her talk today is going to touch on race and treatment. So join me in welcoming her.
Is this working? Can people hear me? Amazing. Is it better? Everyone can hear me with my mask on though? Great. Okay, this is not connecting, so I'll stay in one place. But hi, my name is Cameron, as previously mentioned, first year clinical psych program, and my project today is race and attitudes towards treatment seeking. Great. So this is the current state of the world, where within any given year, 1/4 of the US population meets criteria for a mental health disorder. However, less than half of those who meet criteria then go on to seek treatment. Even when we have available treatments available, the people who need help are not getting help. And this has many unintended negative consequences, such as unstable employment, interpersonal instability, violence, educational impairment, physical health difficulties, and suicide. These negative consequences significantly impact people of color, where Black Americans are about half as likely as white American counterparts to seek treatment, but they experience more functional impairment. There has been some inconsistent findings in this area, where some studies report that Black Americans seek treatment out at equal rates, and some studies reporting they seek treatment out at less rates. However, because of such negative consequences, I still wanted to know, why would someone not seek out treatment? So one study we can look at to answer this question is in a sample of low SES minority women who were experiencing current psychological distress. They were asked reasons why they didn't seek treatment. 83% cited cost as a reason, 46% cited time, 33% cited transportation, and 20% cited childcare. Together, these are known as enabling resources, and the current study aimed to address those resources, as well as two others: information and service availability, which I'll get to later in the method section. But we wanted to know, while addressing these enabling resources, why would someone still not seek out treatment? So we wanted to know who will go to that therapist couch. One reason area of research to look at would be an attitude research. So I don't need to define attitude to this audience, but what we did was, our definition was an evaluation of an object, in this instance treatment, ranging from negative to positive. And past research has shown us that in general, attitudes predict future behavior with some moderating effects, just such as how stable, accessible certain an attitude is, as well as any direct experience or norms. In the context of mental health, it's been found that your attitudes toward treatment and service use are positively associated. And Black Americans are less likely to have positive attitudes toward treatment seeking. They have more negative attitudes. Again, there's been some inconsistent findings here as well, with some studies reporting equal attitudes between Black Americans and white Americans, and some studies reporting Black Americans having more negative attitudes. This brings me to the aims of our study. One, I wanted to replicate past racial differences in treatment-seeking behavior and attitudes. So I believe that white Americans will seek treatment out more and have more positive attitudes toward treatment. We also want to replicate that attitudes predict treatment-seeking behavior. And the new question is this above relationship moderated by race? We believe it will be stronger for white participants than Black participants because of two moderating effects I mentioned earlier, which are direct experience and norms. So we didn't measure these directly, but they helped build our hypothesis for why we think the relationship would be stronger for white participants. In terms of direct experience, past research has shown us that the attitudes of your social network are more likely to influence your treatment-seeking behavior, and people are more likely to have friends of the same race. That means any given white person is more likely to know another white person who has sought treatment, providing direct experience that a Black person's social network might not have. In terms of norms, it's been found that ethnic minorities report seeing treatment as less normative, and it has more stigma, and that stigma is associated with less service use. Oh my goodness. Don't look. Okay, great, sorry. Stigma is associated with less service use. So what these two things highlight, though, is what we're actually studying here is racism. I'm not studying race. That the effects that exist are because of society's racist barriers that we have in the system we live in that makes treatment seem less appealing for certain racial groups. There is not something inherent to Black people versus white people that account for this, but rather it's racism's effects on people. However, our current closest proxy to studying racism will be through race. this brings me to who my participants were. They were recruited from a family practice, and when they arrived at their doctor's appointment, they filled out a PHQ, which assessed their depression. Those who were high in depression were then referred to this study. This resulted in 43 Black participants and 64 white participants. Then all the participants did a baseline questionnaire packet, including the attitudes towards seeking professional psychological help. An example of a question from this survey would be, there are a few times when I felt completely lost and would have welcomed professional advice for a personal or emotional problem. People would then rate this on a scale of 0 disagree to 3 agree. Then participants went through one of 3 interventions. The first one is the enhanced referral one, and everyone here received a thorough referral source packet that was treatment options near them that was pre-screened to match their insurance provider, as well as had free options. And this covered the enabling resources that I mentioned earlier. So it covered cost in the fact that there was a free option or through their insurance. It covered, It covered transportation, as some of the options were within walking distance of where the original study was conducted. So if they could make the original study, they might be able to walk across the street for the treatment. It covered childcare that was offered through some of the options. It covered information, as we gave them this packet, and service availability, as it was only treatments that were accepting new patients. The only enabling resource we did not cover was time, and that's good. I get to that in my limitations. The other 2 interventions someone could have gone through was a psychoeducation one, where they also received the referral source packet, as well as a 15-minute psychoeducation about the benefits of treatment. And the last one was a hope intervention, where they were taught hope skills, specifically pathways. 4 to 10 weeks later, after one of the interventions, participants were asked about their treatment-seeking behavior. We asked, did you try and see a psychologist, psychiatrist, social worker, counselor, etc.? Those were all collapsed together to have the binary question of, yes, I tried to seek out professional help, and no, I did not seek out professional help. To test for racial differences between that binary question, we use a chi-square test, and we use a t-test to see racial differences in attitudes. And then to see if attitudes predicted behavior and if race moderated that relationship, we use a logistic regression. And all this was done controlling for treatment conditions. So it's above and beyond the 3 things I had mentioned earlier. Cool. So our first result is in the left graph, we could see that there is racial differences in treatment seeking behavior, where 73.44% of our white participants went on to seek treatment, while 53.66% of our Black participants sought treatment. The right graph shows that there was no differences in attitude. So looking at this, there is some good news. As I mentioned before, only about half of people go on to seek treatment, and that's even less rates for African Americans. However, in our sample, more than 50% of each group went on to seek treatment. So it seems that our interventions were helpful. It seems addressing enabling resources were helpful in terms of getting everybody to go see treatment, but we don't know why that difference still exists. Cool. And then here we wanted to see if attitudes predicted behavior, and we found that they do. So for every unit increase in attitudes, the odds of seeking treatment increased by 5%. In terms of race predicting behavior, we found that they do. So for the odds of a Black person seeking treatment are about 60% less likely than a white person seeking treatment. And then the new question was, does race moderate the relationship? And we found that it did not. So that means the relationship between attitudes and behavior was the same for our 2 groups. So in conclusion, attitudes do predict treatment-seeking behavior. And despite similar attitudes, Black participants were less likely than white participants to seek treatment, and race did not moderate the relationship. I did forget to mention, despite similar attitudes on the graph slide, they were both positive attitudes. So it wasn't that both people had negative attitudes or neutral, all groups had positive attitudes. So it was the same positive attitudes between the 2 groups. That's also some good news. And then this brings me to my implications that since race did remain a significant predictor of treatment-seeking behavior, that means something beyond attitudes is driving this differential treatment response. One future moderator we could look at would be outside forces disrupting the treatment seeking. An easy one to think of would be, for example, finances. However, our current study did address enabling resources except for time. This could lead to 2 things. One is that we actually didn't address enabling resources in an equitable way. It could be that the solutions we offered were not equally helpful for both of the groups. It could have helped one or the other. And since we didn't measure if they were actually helpful, we won't know that. It could also be that there's other barriers that exist that we just didn't know or couldn't address given the time restraints. Yeah. So we aren't sure if we actually controlled for those. In terms of time, there was a time difference in commitment between seeing a medical doctor. So this is a sample who made their own medical doctor's appointments and went to that appointment. And there is a time difference between that and seeing a mental health doctor maybe 3 times a week. But we wanted to look at other moderators besides time. And that brought us to the experience of distress. So one 20-year-long study found that the only consistently and highly predictive factor of service use was subjective distress, and this was above and beyond enabling factors. So maybe we could look at subjective distress as a future avenue. One study that can point us in this direction is that when they asked white people who were depressed to rate their hopelessness and attitudes, they reported feeling hopeless and having negative attitudes. But Black people were depressed, they reported hopelessness and positive attitudes. So it seems that Black people can hold 2 competing viewpoints and therefore experience, in this example, depression differently and experience distress differently. And then the last point I wanted to drive home that this is racism. I'm not studying differences in Black people versus white people. There's not that inherent difference, but rather, as I've mentioned, these societal barriers that Black people have to live in day to day, getting used to racism in their life. By getting used to racism, quote unquote, it's not acceptable, but it is a daily life struggle, and it might be hard to disentangle when your stress is due to psychopathology or it's due to racialized stress, which is an accepted part of living in society. So for Black people, they may be less socialized to psychopathology, which means they won't know when to get treatment if they don't know they have psychopathology. The last thing I wanted to mention about this racism topic is that any interpretation about Black people would be the wrong interpretation. Rather, we should focus on studying racism's effects on Black people rather than Black people. And this racialized stress idea could be a future avenue. That is the end. Thank you, my lab and my life, my partner and dog. Any questions? Oh, yes.
Were they asked about whether they sought support in other non-medical or therapy contexts, like from my pastor, from my friends? Like, I'm wondering if there's a difference in support seeking within different types of social networks.
Amazing question. Great question. So we actually did ask people if they sought out a religious advisor. However, the numbers were too small to make any comparison. I think only 6 people off the top of my head reported that they sought out a religious advisor, but it was one of our options. A bigger sample could eventually answer this question. Yes.
I may have missed this or like didn't pay enough attention. If you said this already, I'm sorry. Did you measure anything about not like their attitudes towards this, but their expectations of receiving adequate care?
Good question as well. We did not do any expectations. It was just attitudes. End of my point. It's a good question, and I would want to future look at expectations, but this current one did not assess that.
I just mentioned it because I think there was some research about like long-term side effects of like Tuskegee experiments and people's expectations about actually being able to go to a hospital, not, these sorts of things. So, which would fit, I think, in your model, but yeah.
Thank you. Yes.
Do you think this would generalize to people who are now willing to participate in a research study? Like if you are willing to sign for a study that might be ready, make you more likely to seek treatment or something else. Is there any way we can get around that? I keep thinking of it.
Yes, that is a hard question that basically applies to all the research and people who also go on to seek treatment. The people we're seeing are the people are selected sample already. So I have not thought of a better way, but we can't force people into treatment or anything like that. But yes, this all does keep in mind that this is a selected sample of people who would be willing to even do a study. So that is a good point. Yeah.
When you kind of mentioned this too, were the Black and white patients, were they similar in the PHQ-9?
Oh, that's an amazing question that I should know the answer to. We do have the data. I don't, off the top of my head, I don't remember any racial differences in baseline, but I could be wrong. I do know that baseline depression did predict treatment-seeking behavior as well. Doesn't answer your question, but that is something we also looked at in terms of severity depression levels. I don't know off the top of my head between the 2 races.
Great, thank you, Cameron.
Thank you.
Next, we're gonna have Vanessa.